will skip that. I will rapidly. Okay.
Okay.
So there will be
Okay,
not much of problem. I think.
Only request you to adjust your camera, sir.
Oh, that I will do. I will do. Okay.
Yes, sir.
So now I have to exit now.
Yes, sir. Yes, sir. You can stop sharing. Just stop sharing your screen.
Yes. Stop share. Okay. Okay.
Yes. Now it's. You can stop your video also, sir.
Yeah.
If you want, you can adjust the camera and then.
Yes. This is just.
Yes.
Is okay.
Yes. Yes. Absolutely fine, sir.
Light is okay. Light, sound.
Yes. Yes. Yes.
No
Lights are
problem.
light. I think everything is okay, sir. There is no issue.
Okay. Okay. Okay.
We shall be transmitting it, sir, in YouTube also. Yeah, Dr. Jha, you are visible. Dr. Jha, can you hear us? Okay. So
Yes.
Okay. So can you share one slide only? Just share your screen. Just for the checking.
Yes.
Only first slide.
आज आर्टिफिशियल बैकग्राउंड नहीं रखते, आर्टिफिशियल बैकग्राउंड हम नहीं रख रहे आज हटा दिया ना। आशीष जगह कितना बड़ा होगा?
Good evening, sir.
Is it?
कितना बड़ा मुझे?
You can click on share screen and then you can share. First you open your slide, then you click on the share screen. Yes. It's not yet visible.
Visible?
No, not yet visible. It has come that you are sharing your screen.
No, you go to the first slide, Ashish. Yeah, you are there. Just make it a slideshow. Yeah, that is perfect. मेरे को लग रहा था आशीष मुझको क्या थोड़ा सा आशीष
Sir.
How is Kamal's internet today? Dr. Chetri?
Good evening, sir.
Good
Dr.
evening.
Goenka, sir.
Yes,
Dr.
Master.
B.B. Pal here, sir.
Yes, I can see you.
Yes.
Kamal, can you hear me?
Yes, sir, I can hear you. Good evening, sir.
Good evening.
I can see you, hear you. Can you see me, hear me?
Yes, today, yes. Yesterday there was some problem.
There was some problem. Today you can see.
Yesterday you are not in a good mood. Today you are in a good
No,
mood.
no, not me, the net, sir.
All right, where is Sushant? Sushant? Yes.
Yes, sir.
So
Yes, sir.
Sushant, is Dr. Konar there?
No, sir. Dr. Konar is joining. I just
Okay. Sujit, I can just see. So the plan is that Dr. Konar will just speak one or two lines, and then I'm going to show 3 or 4 slides.
Yes, sir.
Do a slide share first, and then followed by me, Sujit will present, and he has 20 minutes. Sujit was asking for more time, but I told him to restrict it 20 minutes.
Not okay. Okay.
He has,
I will
he has
listen.
lot to speak, it seems.
Good evening, Sujitda.
Ashish,
Hi,
how
sir.
are you, Ashish?
ठीक আছে
आशीष इतना टेंशन में क्या है?
नहीं, ठीक है सर।
हाँ, are you okay?
Yes, sir.
All right. Okay. So is the same link for others also? Sushant? For the audience also it is the same link?
No, sir. It is a different link for different. Dr. Konar also has joined. It is a different
Good
link.
evening,
Okay.
Dr. Konar sir. Good evening,
Yes,
sir.
yes.
Ashok da,
Follow.
so I just prepared 4 slides. So say what is refractory ascites just to speak something. All right. And I requested Sujit not to repeat the same thing.
I think, yeah, it's between us, so you have to make it smart.
Yeah.
You
So
have just
you
you
are
have just
introducing.
finished. You have just finished another webinar, I suppose. Now 4:30
No,
to 6.
I ditched them a little bit.
So I think whenever you say I'll just start and then I'll hand it over to you.
All right. So I'll just show 4 slides. Then it's Sujit, Ashish, and then we will have about 9 questions for Sethi. Sethi, I don't see as yet. Sethi, Kamal, and Bhaskar.
Hello, Kamalda. How are you, sir? Oh no, he will not see me.
I think who is the host today? Is it Sushant or Shubhabrata or someone? He
Sushant.
has to screen sharing and all.
Sir, it is Subhabrato.
So can I just see
So let
Sushant?
him start. Let him start saying that welcome everybody and all, and then he can invite the chairperson, and I would hand it over to Dr. Goenka.
So Sushant, can I just see my slide sharing? Can somebody give me the power to share my slides?
That's what
Sir,
I'm saying. So
Sir, you can share the screen.
Okay.
Sir, you can share the screen.
all
Everybody.
right. Oh.
Everybody has
Only
the
the
control
host.
here.
Hello.
Also have joined.
Good evening,
Yeah.
sir.
Good evening. Okay. So is the slide seen?
yes,
sir.
Yes, yes. Can be seen.
All right. Okay.
Yes, sir.
So let me stop slide sharing.
so Sushant, is there any welcome address or anything? No. Then we can
He
start.
says they cannot talk. They cannot talk by their legal reasons.
Right. It is. So we'll start.
Yes,
Yeah,
sir.
you will
We will
but
start
I
at
think-
6:30. 6:30.
Sir, 5 minutes to go.
Yeah. 6:30, sir, you will start.
You can start 5 minutes earlier. What is the problem,
No,
Sushant?
sir,
No, no, we
actually,
need some
we have
audience.
given the time all India, everybody.
Okay.
So that is the reason, sir. Invitation, it is 6:30.
I can get more time.
Ujit is so greedy.
About time.
Sethi is very colorful shirt today.
Sir, Dr. Goenka, sir, can you adjust your camera? Because your camera is
I know.
from the
I know.
lower side. If you can adjust your
Yes.
directly, not facing the camera.
I know.
Sushant, সুজিতের কি হলো একটুখানি looking.
আমি তো ল্যাপটপ খুলেছি
ও একটুখানি আবছা দেখাচ্ছে আর কি।
ওই জন্য একটু আবছা আছে, প্লাস ল্যাপটপের জন্য আর একটু লাইটটা কম আছে।
লাইটটা না একটু লিটল বিট হেজি আর কি, দ্যাটস হোয়াট আই এম সেইং।
হ্যাঁ হ্যাঁ
Pradipta Shetty is bright and you
Ekdam,
know,
No, no,
bright,
Ashish is the brightest today.
একদম।
Bhaskar is
Ashish
sunny.
is brightest.
ভাস্করের ব্যাকগ্রাউন্ডটাও খুব সুন্দর বলে ওই জন্য আরো ভালো আসছে ছবিটা।
হ্যাঁ, ভাস্করটা দারুণ দেখাচ্ছে।
ব্যাকগ্রাউন্ডের
This is my fixed Zoom and all webinar because we do it here.
Chetri seems to be talking from a tunnel, you know. कमल छतरी को देख के लगा रॉकेट
হ্যাঁ
में,
কমল
रॉकेट में
Yes, yes. Almost
राकेश
is
था ना,
looking like
राकेश
that.
दुनिया इंडिया ऊपर से कैसा लगता है?
It is 18:27, so we'll wait for another 3 minutes. Mahesh, can I ask you something?
Yeah, sure, sir.
That's about the SGEI. Our DNB students, they need to register and they need a
Yeah,
letter.
so
or
they go on the
something.
site. They go on the site and register it. They
Yes.
have to just write that they are a student.
They need a certificate, I think. It's not,
If you can upload, otherwise your name is enough.
They want a certificate from the institution that they are bona fide student or something.
If you can give it, it's fine. Otherwise, you tell them that they put your name and we would clear it. So we
Okay.
have about 2,500 registrations.
Right. That's on 15th and 16th, isn't it?
15th, we started around, I think, 12 o'clock and finished by lunch on 16th.
$628.
sir, who
Dr. Goenka, sir, Dr. Goenka, sir, can you see the screen, question and answer? Can you open the question from the audience?
Chat box. There is a chat
Yes,
box.
yes. I have
Yeah.
a question answer. I can
Sir-
see. What's the best treatment of refractory ascites caused by liver cell failure?
Yeah. Just click on answer live and then you can. This is just for sample practice.
ठीक है यार 3 महीने
Yeah,
से
yeah,
इस पे
ठीक
काम कर रहे हैं
Okay.
Sushant 3 months we have been doing this only, no patients.
I know, sir. Just we are checking our system only.
आशीष के पास पेशेंट है पटना में, हमारे पास कोई पेशेंट नहीं है.
गवर्नमेंट में तो करना पड़ेगा सर. यहाँ तो बहुत पीक हो गया था, बहुत स्पाइक हो गया था, अभी तो
I
प्रॉब्लम.
know. Sir, All India Institute doing that? All India Institute?
And they are actually All India Institute become a dedicated COVID hospital.
I know, but I've been told no consultants are available. These are all RMOs are treating.
No, sir, it's wrong information. Actually, my father-in-law was admitted there, so I know. Actually, they are doing good.
So we have flooded with COVID patients. There is a huge waiting list in the emergency. Chai. So any news about gastroenterology exam, DNB final?
You might be knowing September? No.
No, they haven't decided the date as yet. Most of the specialty exams are taken
তারপরে করো,
August.
তারপরে মিটিং
But gastroenterology, they have not decided as yet.
নিয়ে আছে গো।
The main idea being that gastroenterology does not have, the students who will pass will not enter any DNB program because there is no DNB program as yet for people who pass DNB. So they are first creating those specialties where they will get students because they will pass from these specialties. Like cardiology, there is something super specialty, there is something. So every specialty which has another course after that, they are doing it first.
Shall we start at 6:30?
Sushant has Indian.
Yes, sir. You can
One
start.
moment.
Dr.
But Sushant, how many people have joined till now? 24.
Yes, sir.
I think
people are joining
Ashok, we should
YouTube.
wait for 2 more minutes. Let's wait for 2 more minutes.
Okay. So there are two. One.
সরি সুমি, তোকে ফোন করতে
That is
পারিনি।
YouTube.
শোন না একদম 6:30 তে একটা ওয়েবিনার শুরু হচ্ছে।
So shall we start, Sushant?
আমি কথা বলবো,
Yeah, request Yes, sir. Request everyone to be on mute.
তুই কি কলকাতায় চলে এসেছিস? কলকাতায় আছিস?
1
Okay,
minute, sir.
we'll
Please hold on.
make
Sujit,
yourself mute.
সুজিত, তোমার
Everybody
পেশেন্টের
make
সম্বন্ধে আমরা জেনে
themselves
যাবো
mute.
সব।
Currently, people will keep on talking. Please
sir.
mute yourself.
Yeah. So we have to mute. Actually, we
Yeah.
were chatting. For that, we have not muted it. Okay.
No. Now you should mute to start. So welcome everybody. Today we are having a seminar on ascites and refractory ascites, which is really very important for all the practicing gastroenterologists. Straightway, one can say that even in the Western countries and everywhere, this is an indication for referral to transplantation. That means that without transplant, the mortality seems to be very high. So it's a very important topic for all of us, because we do not send them for transplant. We keep on treating them with many things, then that we are going to discuss. But if the one answer is that if you have a patient who is in refractory ascites, probably he should be referred for transplant. With these few words, I would hand it over to Dr. Mahesh Goenka, who is going to moderate the whole session and to really set the ball rolling. And I would invite him to start the ball rolling and then ask and introduce the speakers. That is Dr. Sujit Chowdhury and Dr. Ashish Kumar Jha. Subsequently, Dr. Goenka, please.
Thank you, Ashokda, and good evening, everybody. My thanks to Mylan for organizing this platform for interaction on a very, very important topic. My role is just to set the context, and I would show that in about 4 or 5 slides, which I prepared just now. So all of you who are practicing hepatology and gastroenterology know that ascites is one of the most common complications of chronic liver disease. Now, while majority of ascites is easy to treat, we'll end up in about 5 to 10% of the patients, which we call as refractory ascites. And we also know that refractory ascites is associated with a very high morbidity and mortality. And some of the data show that once you have refractory ascites, the mortality at 6 months after that is as high as 50%. Now, the ascites is caused, as we all know, by splenectic vasodilatation, which leads to arterial underfilling and sodium retention. The treatment, as Dr. Ashokanand Kona just now told you, once it reaches a refractory ascites, the treatments are very limited: large volume paracentesis or total volume paracentesis, TIPS, transplant, and in some case, peritoneal venous shunt. We'll be dedicating today to the topic of a relatively new drug. I won't call it a new drug, but relatively new drugs, which we have all started using for a couple of years, which is an oral alpha-1 adrenergic agonist, midodrine. Now, let's pass on to the next slide, if it goes. 1 second. Now, this is a common slide which all of us have seen, those who practice hepatology, is that sometime back in 2018, Diesel, Amico, divided chronic liver disease into compensated stage, which is asymptomatic, with a median survival of 12 years, decompensated, which is symptomatic, with a median survival of 2 years, and finally end-stage disease, which is late decompensation. And it was found that from a compensated to decompensated, the rate is about 5 to 7% per year. And it was further divided. The compensated liver disease can be stage 0, which is no varices, mild portal hypertension; stage 1, which is no varices and clinically significant hypertension; and stage 2 means there are varices, but it has not bled. Now, when the decompensation takes place in the stage 3, there is bleeding from the varices. Stage 4 is first non-bleeding decompensation, which will include ascites. And stage 5 is second decompensating event, which can again be ascites or some other complication. End-stage disease means late decompensation, which is refractory ascites comes here, persistent protocystic encephalopathy or jaundice, infections, renal and other organ dysfunction. And here there is ACLF will also come in the stage. So today we are going to talk primarily about end-stage treatment, and we would be concentrating primarily on refractory ascites. I'm sure Dr. Sujit Chowdhury and subsequently Dr. Ashish Jha will tell you as to what is the definition of refractory ascites. But the common definition is by the International Ascites Club, which called refractory ascites as either diuretic resistant or diuretic intractable. Diuretic resistance ascites means that ascites that cannot be mobilized or the early recurrence within few days of which cannot be prevented because of a lack of response to sodium restriction and diuretic treatment. So somebody who has received proper diuretic, which literally means furosemide of 160 milligram and spironolactone of 400 milligram along with sodium restriction. That means we have been able to reach this dose of diuretic, but the patient is not responding. The second group of refractory ascites are diuretic intractable or intolerant. That means patient develops some complication related to diuretics and cannot be given the highest dose of diuretics. And what are the complications? Complications can be hepatic encephalopathy, renal impairment, hyponatremia, abnormality in the potassium level, or incapacitating muscle cramps. So all of these will make diuretics increase in the dose unlikely, and this will be called as one of the ways of defining refractory ascites. Another term which has been used is recurrent ascites, which means the development of tense ascites on 3 or more occasions in a period of 12 months in spite of standard high-dose diuretics with or without large follicular paracentesis. So recurrent ascites is something a little different from refractory ascites. So we will be now listening to Dr. Suchit Chaudhary, who is a senior consultant in AMRI Hospital, Calcutta, and he would be giving an overview of the management of refractory ascites. Thank you. Dr. Suchit Chaudhary, Dr. Konar, you want to say something? Can you invite Dr. Suchit Chaudhary?
Where is Shujit? Dr. Shujit Chaudhary, are you listening to us?
You have to unmute yourself. You have to unmute, yes.
And
Ashish,
Please
can you
start.
mute yourself? Ashish, can you mute yourself?
You already muted.
can you see my slides? Sushant? Hello.
Sir,
Hello.
not yet. It is coming. It is coming. Not yet.
Not yet.
But it is okay. It will come.
Huh?
It is
It does not come.
Sujit
Is
Chaudhary
it?
has started screen sharing.
You go to the next slide, it will come. No problem.
Whether my slides are visible?
Not yet. Can you go to the next slide? Then it will come. Go to the next slide.
Is it coming? Not yet.
No.
Should I again stop share and again I am sharing again?
Sir, your slide is slide presentation mode, I hope.
Yeah.
Your slide
see
you have
now?
already. No, have you make your slide presentation mode? Not yet visible, sir.
Not yet.
Kindly double click to
Is it
Go
now
to the
visible?
slideshow version, slideshow.
Okay.
Have you clicked on your slide?
Actually, I have opened the slides and then
You can see the first slide. Can you see your first slide?
let me
You see your first slide, then it will come. You have to show your first slide to yourself first.
Can you see?
Now it's coming. Now it's coming.
It's coming.
Yes. Now it's there. So you just go to the slideshow. What is slideshow? Yes. Click that. Click that.
Oh,
Yes.
okay. Is it visible now?
Yes, it's visible.
Okay. Okay. So, good evening. Am I audible also?
Yes, very well.
So, good evening and respected my seniors, Dr. Konar, Dr. Goenka, and also my colleagues. So, I'm happy to share my experience and knowledge regarding refractory ascites already has been introduced by Dr. Goenka, that the multi-stage model of clinical course of cirrhosis. I don't want to repeat it. And you know that the transition from compensated to decompensation occurs in the tune of 5 to 7% per year. And decompensated cirrhosis is considered as a systemic disease and with a multi-organ and multi-system dysfunction. So asymptomatic, the survival is 12 years, but when it is decompensated is asymptomatic, but decompensation is symptomatic, and the median survival is 2 years. And this is the pathophysiology of decompensated cirrhosis. The modern hypothesis is that cirrhosis is a systemic inflammatory, decompensated cirrhosis is a systemic inflammatory disorder. And when there is portal hypertension, there is bacterial translocation from the gut, and there is activation of the different pathogen associated molecular pattern. And when there is simultaneously, there is liver inflammation with ongoing apoptosis and cell necrosis, there is damaged associated molecular pathogens are activated. And these two factors ultimately activate the immune system, the innate pattern of recognition of the receptors in the immune system, and there is activation of the inflammatory cytokines, reactive oxygen species, and reactive nitrogen species. And this is responsible for the splenic arteriolar vasodilation along with along with portal hypertension. So ultimately, this produces organ dysfunction. So when there is a mild form of disease, there is a splenic arteriolar vasodilatation, and initially the cardiac output is normal, but as cirrhosis progresses, cardiac output is increased. And later, ultimately, when there is severe splenic arteriolar vasodilatation, then the cardiac output is reduced. And in the advanced stage, there is severe hemodynamic compromise and organ dysfunction. So this pathogenic mechanism for severe is important for management of advanced decompensated cirrhosis. So the ascites is associated with reduced mortality, and compared to the survival is more than 80% when there is no ascites, in about 100 months survival, but it is significantly reduced to 40% when there is ascites is complicated with one episode of spontaneous bacterial peritonitis. The 60-month survival is around 40%, but if there is a refractory ascites or hyponatremia, survival is reduced to 20%, and HRS, the survival is almost nil. So the ascites with its complication associated with significant mortality. The ascites management, the mainstay of management is sodium restriction, because the main pathogenic mechanism, as Dr. Goenka has mentioned, that is reabsorption of sodium and water, rapid reabsorption, and salt and water retention because of the activation of renin, angiotensin, aldosterone mechanisms. So always you should try to avoid IV saline when the patient is hospitalized, except when there is gross deficiency because of diarrhea, vomiting. So, and the diuretic is the mainstay of therapy, and the aldactone can be started initially, and then later you can combine with furosemide, that is Lasix, and the maximum dose is 400 milligram of aldactone, and Lasix is 160 milligram. But if the patient is not responding to diuretic, the paracentesis should be the treatment, and then it should be associated with intravenous albumin. I will mention later, and what are the benefits of albumin. And all of us know that you should give albumin around 6 to 8 gram per liter of paracentesis. The problem of ascites management is acute kidney injury and hyponatremia. That you can manage the acute kidney injury by intravenous albumin. Hyponatremia, there is some role of tolvaptan. The tips has to be considered. I will discuss about the tips, particularly in refractory ascites if it is associated with hyponatremia or AKI. The calorie consumption, when there is ascites, the calorie consumption is reduced. And this study showed that the baseline, the total tolerated volume, because of the gastric inability, gastric lack of accommodation of the stomach. So the volume intake is reduced and calorie intake is reduced. But after large volume paracentesis, there is significant improvement of calorie intake and maximum tolerated volume is significantly high. The severe ascites, and edema, the benefit of IV albumin, the dose here is mentioned about 25 grams 6 hourly, 25% albumin, but that sometimes may not be able to give in because of other, but it is if you give, if there is a significant serial improvement by days, there is reduction in the body weight and improvement of the urine output. And so, and if the albumin should be continued till the serum albumin is normalized, the serum creatinine becomes normal and hyponatremia is corrected. And this showed this study that the hyponatremia and AKI, by giving intravenous albumin, the sodium gradually improves, hyponatremia is corrected, and creatinine is gradually reduced in patients of AKI. So the easels, these practice guideline, clinical practice guideline recommendation in 2018. This study is, well, I have many of the slides. I have shared the slides from that only. That when there is a large ascites, the grade 3 ascites, large volume paracentesis under strict sterile condition is a treatment of choice, and ascites should be completely removed in a single session. That is called also total paracentesis. The contraindications are very few, and you should not be scared if there is low platelet count, if there is the high INR. But if there is severe coagulopathy, particularly DIC, definitely it is one of the contraindication. Uncooperative patient, abdominal skin infection at the puncture site, pregnancy, severe bowel distension are the relative contraindications. So large volume paracentesis, I have already mentioned, should be followed by volume expansion with intravenous albumin. If you remove if less than 5 liter, even by giving albumin, though the risk of post-paracentesis, the circulatory dysfunction is significantly less, but still albumin is still recommended. And after the large volume paracentesis, you can restart the diuretic with a minimal dose necessary to prevent the reaccumulation, because ascites will recur after large volume paracentesis. And large volume should be performed even in patients with AKI or SBP. It is not a contraindication. If necessary, you can do large volume paracentesis. This has been already described, but the definition, this is the usual standard definition accepted in the world, that International Ascites Club defined refractory ascites when the ascites cannot be mobilized, or there is early recurrence of the ascites which cannot be prevented by the medical therapy. And it has been categorized 2 types: diuretic resistant and diuretic intractable. Resistant means there is lack of response with the highest dose of diuretic, as I mentioned, that 400 milligram of spironolactone and 160 milligram of furosemide. And the intractable, that is development of diuretic induced complication, you cannot give the highest dose of diuretic. This has already mentioned also that the body weight, that is a lack of response, the weight less than 800, less than 0.8 kg over 4 days, and urinary sodium output is less than the sodium intake, that indicates lack of response. And the treatment duration, the patient must be on intensive diuretic therapy for at least 1 week with a salt restricted diet of less than 90 millimoles. 90 millimoles is approximately about 5 to 6 gram of sodium chloride per day. So that you have to define that this is not diuretic responsible or diuretic, and the diuretic that is refractory. And when the diuretic induced complications, that what is the definition of recurrence? That is, recurrence means reappearance of grade 2 or grade 3 ascites within 4 weeks of initial mobilization. And the complication already mentioned, that the diuretic induced complication like hepatic encephalopathy, renal impairment defined as creatinine more than 100% to a value of more than 2 gram per DL, or in a patient of ascites responding to treatment. Hyponatremia, either reduction more than 10 millimole or it is less than 125. But potassium less than 3 or more than 6 millimole per liter. This is important, or if there is intractable muscle cramp. So refractory ascites, the poor prognosis, already I've mentioned that 6 month survival is 50 to 75%. The mortality is 50%, around 50%, and 1 year about 75%. So the diagnosis of refractory ascites on the assessment of response of ascites to diuretic therapy and salt restriction, and evaluation should be done in a stable patient. That is very important. And the standard of therapy for refractory ascites is liver transplantation. So, and there is some fallacy for the MELD score for detecting, for categorizing the patients of liver transplantation. As you know that the INR and this is the ascites and other parameter. For that, it is modified as MELD NA. For the sodium has been included. So management of refractory ascites, the other than liver transplant, is large volume paracentesis, tips, vasoactive drugs, vasoconstrictive drugs, and there is the automated low flow ascites pump called alpha pump. The leave-in shunt is obsolete because of the now at present, never, it is now at present not used anywhere because of the complications. So, but there is some data on this pump. So I will try to mention, I discuss that. So refractory ascites management is LVP, that is safe and effective, and drug treatments are controversial according to the EASL guideline, that is midodrine and other drugs which I will describe, that it is still not yet recommended according to the EASL guideline. Okay, so it is inadequately studied and the data are generation. So according to the guideline, it is still not recommended. So repeated large volume paracentesis plus albumin is the standard therapy for refractory ascites, and diuretic should be discontinued in patients with refractory ascites who do not excrete more than 30 millimole per day of sodium under diuretic treatment. So you should stop. But if on diuretic that sodium excretion is more than 30, then you can think of continuing diuretics. So although controversial data exists on the non-selective beta blocker in refractory ascites, the cautious, there is controversial, but the cautious should be exercised in severe cases when the high dose non-selective beta blocker should be avoided. Propranolol more than 80 milligrams should be avoided, and carvedilol cannot be recommended at present. The level of recommendation grade is 1 and grade of recommendation is 2 recommendation. So there is this study that showed that beta blocker impact on ascites. If the patient on beta blocker with ascites, the mortality survival is significantly lower than those without beta blocker. So the survival is around 40%, those without beta blocker, and it is less than 20%, 36 month survival when the patient is on beta blocker. Another, these data that the beta blocker impact on spontaneous bacterial peritonitis, the AKI and the HRS is significantly high when the patients on beta blocker compared to without beta blocker in patients with ascites. So the other treatment is tips. The tips, you know that is putting a stent, either initially the data on uncovered stent, and now this covered stent is used between the portal vein and the hepatic vein, and this bypasses and decompresses the portal venous system. And so the tips, according to the EASL guideline, the tips the short term, it accentuates the peripheral vasodilation, the mechanism, and within 4 to 6 weeks improves the effective volemia and renal function. So the patient should be evaluated for tips when there is refractory or recurrent ascites and the paracentesis is ineffective. And it is recommended with recurrent ascites as it improves the survival, and with refractory ascites, it improves the control of ascites. And the use of small diameter, this covered stent, PTFE covered stent, is recommended to reduce the risk of tips dysfunction, and hepatic encephalopathy is significantly reduced if the tips diameter is 8 millimeter compared to 10 millimeter, and if it is covered stent. So after the tips insertion, continue the following until that is either diuretic can be continued and salt restriction should be continued, and close clinical follow-up is necessary. This is earlier study by Chanel which showed that tips does not alter the mortality. It improves the control of ascites, and for patients with refractory, that is called NASTRA study, not that American study for refractory ascites, that tips control the ascites, but there is no change in the mortality. These are the data of different the studies comparing the tips versus large volume paracentesis. The control ascites is much better with tips, but encephalopathy worse with the two studies, about the three studies, but there is no difference in the earlier studies. But survival, the only the two studies showed that a better survival, but other studies there is no difference, and one study showed worse with tips. So as a tips, that is better control of ascites, but chance of encephalopathy, but it is much less, as I've mentioned by covered stent. And the caution should be that renal parenchymal disease on dialysis are not a good candidate, and they may not respond well, and do not withhold the diuretic. And the new entry PTFE, I have mentioned that it is better, patency is increased, and greater survival. And contraindication, if it is more than 60 or this relatively elderly age is a contraindication if there is portal vein thrombosis, hepatic and history of recurrent hepatic encephalopathy, INR, presence of spontaneous bacterial peritonitis, cardiac dysfunction, and child C cirrhosis, particularly the score more than CTB score more than 11 are contraindication for tips. Now the drugs, the vasoconstrictor drugs, midodrine is the important drug which has been tried both in refractory ascites and also hepatorenal syndrome. I will discuss about the role of midodrine in refractory ascites. The midodrine is a prodrug, and it is converted to the active metabolite desglycimidodrine in the liver, and which is a alpha-1 receptor agonist. And so stimulate activation of the alpha-1 adrenergic receptors of the arteriole and the venous vasculature. So increases the vascular tone and elevate the BP. So, but it has no effect, active component, no effect on the heart. So, no, it does not cross the blood-brain barrier. So there is no CNS side effect. And because of the increased systemic circulation, there is improved renal function, and there is increased sodium and water excretion, and so improvement of ascites. And the absorption is the peak plasma half-life is about 25 minutes, peak plasma concentration of half an hour. Active component, the peak plasma half-life is around 3 hours. The availability is about 93% bioavailability, and eliminations, mainly the active form is eliminated 80% by the renal renal secretion. The starting shot should be 5 milligram 3 times daily. That adjust the dose by increasing increment of 2.5 milligram for each dose every 24 hours. The maximum dose can be up to 17.5 milligram 3 times daily to achieve and increase the systolic BP to 10 to 15 millimeter mercury. And midodrine must be taken during the day. You should avoid the medicine at night, and the patient should take at least 4 hours before going to bed, because it can produce supine hypertension, and that can be very much symptomatic also. So that should be avoided. The data, the study from PGI Chandigarh by Virendra Singh et al. Published in 2012. So it showed that midodrine, when compared to the standard medical therapy, it improved the renal function and sodium excretion, improved the systemic circulation, and reduces the renin activity, and reduces the aldosterone also. So this is data that the survival compared to standard medical therapy, the midodrine at the end of 300 days actually. So it is 5 for in the standard medical therapy, and midodrine 12. Though there is a survival benefit with midodrine, this study showed a survival benefit with midodrine therapy, and it is superior to the standard medical therapy. This is another study from Ahmed Ali et al. That is from Saudi Arabia. So this study showed that the midodrine, it appears to be effective in lowering the body weight and abdominal guard, that is control of ascites, in non-azotemic cirrhotic patients with stents ascites. This is another study from Egypt that Obiadullah published in 2017. So the effect of midodrine in patients with cirrhosis with refractory ascites, they compared the patients with cirrhosis with refractory ascites with standard medical therapy, and the data showed that there's significant weight loss, MAP is increased, and urine production is increased. And they concluded that midodrine is a safe treatment for patients with cirrhosis with addition to standard medical therapy and better control of ascites. So, this is also this is a recent study from the people from Egypt, which showed that oral midodrine is comparable to albumin infusion when you are doing large volume paracentesis. If you can give only midodrine without albumin, and the midodrine is given for 30 days after large volume paracentesis. So it has been found to be effective, as effective as albumin. So, and it is, this study showed that it is as comparable, and the expense will be much less compared to intravenous albumin. The midodrine has been found, some of the other drugs has been combined with midodrine. The clonidine, this is also from the Virender Singh group from PGI Chandigarh. They showed that midodrine, clonidine, and combination of midodrine with clonidine, that this combination is better than the individual midodrine or clonidine alone. And this is another study also from the same institute, which showed the tolvaptan has been combined with midodrine. These results of pilot study showed that the combination is better than individual tolvaptan or midodrine alone. So another study that rifaximin has been used as a combination of midodrine in patients with refractory ascites. Adding rifaximin with midodrine to diuretic enhances the diuresis in refractory ascites and improve the systemic renal hemodynamic, and the short-term survival is better. So the ASLD guideline, which has not been updated till after 2012, which recommended that oral midodrine has been shown to improve the clinical outcome and survival in patients with refractory ascites, and its use should be considered in this setting. But I have already mentioned that the EASL guideline, there is not much of recommendation, but it is still on the process of evolution. The drug therapy, the role is still not yet been well established. So, but the type 1 HRS, the albumin infusion with vasoactive drugs like either octreotide and midodrine should be considered. So this, I mentioned that alpha pump. What is that? I think I have no idea whether it has been used in India. But this is, in European countries, this pump is a automated pump, and it is placed in the subcutaneously in the abdominal wall, and there is catheter drains the ascites from the peritoneum into the urinary bladder. And when the pressure in the urinary bladder is high, the functions stops. And if the pressure in the abdomen, ascites pressure is less, then the pump will not work. So this is a continuous, slowly drainage of the ascitic fluid directly into a bladder without the recourse to paracentesis. So there is some data that it has a significant reduction in the number and volume of paracentesis of advanced cirrhosis, and the efficacy, the median number of paracentesis is significantly reduced to 85%, and there is improvement in the quality of life and improvement in the nutritional parameter. It has been assessed by the Handrich strength and body mass index, but there is no effect on the survival, and there is some serious adverse effect, particularly AKI, that in the tune of 85% versus 45%. So this is still not yet been recommended, but only in experience center has been used, and close patient monitoring is warranted. So I want to show the two slides that whether we are all of us are very facing the problem of COVID-19. Just this is a comment from the experts that COVID-19 cases of hepatic cirrhosis or hepatocellular carcinoma is more prone, particularly in COVID-19 infection, due to their immunocompromised state. And cirrhotic patient may develop ACLF when there is massive inflammatory response. But the data is still on the process, there is on evolving. But at this moment, so there is very limited data. And also we know that in case of COVID infection without liver disease, they can have liver dysfunction, GI bleeding, and hepatic encephalopathy. And the endoscopic procedures should be confined to emergency in the era of, at present problem of COVID-19. And the listing for liver transplantation should be confined to ACLF or high MELD score and HCC at the upper limit of Milan criteria. So, and this is the data that published in May 2020 that experience from Hubei, the one that is of 3 patients, of which 2 died because of cirrhosis complicated with COVID-19, but only 1 patient who presented with variceal bleed, he survived and was discharged from the hospital. So as a whole, commented that there is a cirrhosis is a decompensation, is a risk factor for poor outcome of patients of COVID-19. This is a comment from Michael Pawlowski from France, and published in Nature Review in 2020 recently, that he said that the COVID-19 is a modest effect on liver and liver-related mortality. It is and it is unusual during the course of the disease, except in patients with a severe pulmonary disease. But most patients of COVID-19 induced liver mortality will be delayed because of the deferred care. We are deferring care for the liver disease because of the fear, because we are not the screening for HCC, screening for bleeding. So the reduce, there is funding of the reduce funding for public health intervention and global economic crisis, which will ultimately lead to increase in the alcohol and drug use, and there is more chance of bloodborne viral transmission. The access of care and funding is reduced. So our priority now, the prevention of liver-related mortality following COVID-19 epidemic will require rapid resumption of the care activity, in particular in patients with advanced cirrhosis and hepatocellular carcinoma, and for those requiring liver transplantation, and a massive investment in viral hepatitis elimination effort and courageous economic and social measures to mitigate the health consequence of the coming economic crisis. So this is a comment by Pawlowski. So just I want to share with you. That's all. Thank you for your patience hearing.
So can you can you remove?
Yeah, I'm stopping this.
Okay. So with permission from Dr. Konar, can I now invite Dr. Ashish Jha, who is a professor in Indira Gandhi Institute in Patna, and I had the pleasure that he was working with me in Apollo Clinicals Hospital for a few years before he joined IGMS. So I request Dr. Ashish Jha to give his presentation. He's discussing a case possibly of refractory ascites. Ashish, do you mind people stopping you in the middle of your presentation?
Yes, sir. Anytime. We are welcome, sir.
All right. Okay. So the participant can ask him questions because it's a case presentation. So you can ask questions either during his presentation or at the end. And we have about 20 minutes for Ashish to present his case. Ashish.
And you have 3 panelists.
Yes, the panelists can join now, or maybe we have a session after his presentation. Of course, we have 3 panelists. Dr. Pradipta Sethi, who is the Director of Gastroenterology at Medica, Dr. Bhaskar Pal, who is a Senior Consultant in PLS Hospital, and Dr. Kamal Chetri from Apollo Hospital, Guwahati, also there. So they can join during this discussion. Of course, we'll have a panel discussion after Dr. Jha's presentation. Dr. Jha, please.
Am I visible? Thank you, sir, for nice introduction of mine. It's always pleasure to share stage or webinar with you. So in 15 minutes or to 20 minutes, I will present a case of refractory ascites. So a 45-year-old normotensive businessman presented with gradually increasing abdominal distension, anorexia, and fatigability since 1 month. There were no history of dyspnea, palpitation, fever, loss of consciousness, hematemesis, and melena. He had significant history of alcohol intake since 9 years. He was diagnosed as polycystic liver and kidney disease in 2012. However, his liver and kidney function tests were normal. He had no history of diabetes or other chronic illness except polycystic liver disease. On examination, vitals were normal, pulse were active, blood pressure 118/76, respiratory were normal. General physical examination revealed pallor, pedal edema, and enlarged bilateral. No signs of encephalopathy was present. Abdominal examination showed abdominal distension, dilated abdominal veins, shifting dullness was present. Other systemic examination were normal. Blood investigation showed anemia, hemoglobin of 11, thrombocytopenia, mild raised bilirubin, and liver enzymes. AG reversal, albumin and globulin reversal, and low iron, creatine, B12. Examination showed high anxieties. However, no evidence of spontaneous bacterial peritonitis were present, or ADA was normal. MELD score calculated. MELD score was 13 and CTV score was 7, class B. Ultrasound show polycystic liver, dilated portal vein, splenomegaly, mild ascites, and bilateral renal cyst. Upper GI endoscopy done, which showed the grade 1 esophageal varices without a red color sign or other high risk feature of GI bleeding. Etiological workup done for chronic liver disease was didn't reveal anything. It was negative for viral markers, autoimmune liver disease, Wilson disease, and hemochromatosis. Therefore, a diagnosis of polycystic liver disease, ethanol-related chronic liver disease, MELD 13 and CTPB, portal hypertension, ascites, and grade 1 esophageal varices with nutritional anemia was made on the basis of clinical symptoms and investigation finding. There were no history of spontaneous bacterial peritonitis, hepatic encephalopathy, upper GI bleeding, sarcopenia, and hepatorenal syndrome were noted. The patient was treated with dietary modification, diuretics, oral iron, B12 supplements. High protein diet and salt restriction were advised. Maximum 7 grams per day salt were allowed. Spironolactone treatment was initiated with a dose of 100 mg per day, and then dose was gradually increased to 200 mg per day, and that leads to the satisfactory weight loss after a week. He was referred for alcohol de-addiction, and patient was on regular follow-up every 4 months. However, three months later, he presented with increasing weight and abdominal distension. So therefore, furosemide was added to spironolactone, and dose of furosemide was increased to 80 mg per day, along with the spironolactone 200 mg per day. Again, weight loss aim was achieved after a week, and patient was doing well on 80 mg furosemide and 20 mg spironolactone. He was on regular for 3 months, but unfortunately stopped visiting OPD for a couple of months. Then he presented back with again abdominal pain and massive abdominal distension and respiratory discomfort. This time physical examination showed a pulse rate of 96, blood pressure slightly lower than before, 100/60, MAP was 73, and respiratory rate was little higher, 25 per minute. Physical examination revealed again pallor, edema, dilated veins, and tense abdomen along with the fluid 3. Therefore, a large volume paracentesis was done under strict
Can I ask you a question here? Ashish, can I ask you a question here? Now,
yes, sir.
In a normal practice, do you start with the textbook way of starting with spironolactone and gradually build up the dose of spironolactone and then add furosemide? Because our patients are very, very demanding and they want that a result should come very fast. So are you able to go in a stepwise manner in increasing the diuretics and starting with spironolactone and then add furosemide? Or do you start with a combination of furosemide and spironolactone in most of your patients?
I agree with you, sir. Most of the time, we actually have to start with this combination, but this patient had mild ascites initially. So I on the thought we can start with an spironolactone without adding. So most of the time, the case usually presents with a moderate ascites. In that case, we have to start with.
Can we ask Dr. Bhaskar Vikas Pal whether he does the same or does he start with combination to start with a stepwise manner?
Sir, I think there was an article by Perigenes in while discussing this British Society guideline, gastroenterology guideline, where they have compared this stepped care approach to a, as you have rightly mentioned, they have started directly with furosemide actually 20 milligram and aldactone 50 milligram, and both the, and it showed the studies that are available that they have shown almost similar efficacy, and there was no actually excess adverse events. But the only problem is, I think, if we have these electrolyte imbalances, then only it becomes a bit difficult to modulate the dose of drugs. But for efficacy wise and initial management, I think a combination has got evidence-based support.
Sir,
All right, Ashish, sorry for disturbing you. You can carry on.
can I comment, Maheshda?
Yes, Sujit.
So
Yes,
actually,
Sujit.
but there are some advantage of this step care management, because you know that in case of cirrhosis, the most important factor is the activation of renin-angiotensin aldosterone mechanism. If you start with spironolactone, you are suppressing this activity much earlier, and after that, the active action of the furosemide will be more active. Otherwise, just when you want to treat the ascites very rapidly, particularly for inpatient, then combination should be given. But otherwise, I think the data is more in favor of step care management, that is more scientific, and the side effect of the problem of electrolyte imbalance will be much less if you give a standard dose of spironolactone to the highest dose, and then you can, if the patient is not responding, then you can add gradually and can increase the dose of furosemide.
Ashish hit the nail that in patients with mild ascites, maybe you can start in a staged manner. But when the patient has moderate to severe ascites,
yes, sir, I agree, sir. Even legal guidelines suggest if a patient present with mild ascites, we can start with the.
Maybe we can have some more discussion later on this issue. But let's Ashish continue its presentation. Yes.
So then, because ascites was tense, so large volume paracentesis was done under strict aseptic precaution, and 6 liters of ascites fluid was removed along, and IV albumin was infused during the paracentesis at the with a dose of 8 grams per liter. Repeat test for SBP was done, but it was negative, and the lab parameters were nearly similar to the last test. Dose of diuretics was increased this time up to 120 mg furosemide and 300 mg of the spironolactone. And he was doing good with adequate weight loss for next 3 months. But after 3 months, he again admitted with the tense ascites and respiratory discomfort. This time his pulse was 116 per minute. Blood pressure was further fell to 106 by 66, and respiratory rate was 22 per minute. So oxygen saturation was 96% of O2 support, so 99 on minimal O2 support at the 2 liter per minute. Blood test showed, this time blood test showed decrease in the further decrease in the serum albumin and sodium compared to the last visit. And chest X-ray done revealed that the mild right pleural effusion, otherwise normal. Repeat ultrasound again suggestive of massive ascites, but didn't really relieve any new SOL liver or vascular pathology like portal vein thrombosis or other things. And child score actually increased to 10, and now patient become decompensated, and sodium, mild sodium was increased to 24 this time. So immediate management was started, oxygen inhalation at 3 liters per minute, and again LVP was done, and along with the IV albumin infusion, a repeat test of SVP again done, it was again normal. So compliance regarding the diuretic intake, salt and fluid intake, it was optimal. And an increase in dose of diuretic was done with the furosemide 160 and spironolactone 400 mg. However, mean weight loss was achieved by less than 0.8 kg over last 72 to 40, over the 4 days. And moreover, the patient complains of severe muscle cramp. Therefore, dose of the diuretics reduced back to furosemide 120 mg and spironolactone 300 mg. And urine sodium output was actually measured. That was 40 millimole per day, less than actually 50, but it was more than 30. So based on this, the diagnosis of refractory ascites, diuretic intolerant, a variety was made, and diuretics were continued because sodium output was more than 30, and weekly IV albumin infusion was specific. And then we advised him for the weekly IV infusion along with the large volume parasympathesis. So over 2 month period, he required 6 LVP procedures, resulting in drainage of almost 45 liters of ascites fluid drainage. He was assessed for tips, but radiologist refused because of presence of multiple hepatic cysts. He was also advised for the listing for liver transplant, was refused because unavailability of suitable liver donor. In last 2 months, a patient become decompensation were actually progressive. So his systolic blood pressure gradually decreased to 86 millimeter. MAP was this time 62 millimeter of mercury. Therefore, we decided to add midodrine at the initial dose of 2.5. Actually, we have not experience of using midodrine, so we have started with the lowest dose of 2.5 TID. This dose was gradually increased to 5 mg TID over a period of month. His blood pressure improved from approximately 86 millimeter systolic blood pressure to 96 blood pressure, systolic blood pressure. And then in over the 2 months, the session of LBP was reduced a little, and it was 4 as compared to 6. He was doing reasonably well with the salt restriction, diuretics, weekly IV albumin, midodrine, and repeated LBP. So after 2 months, again he admitted back. This time with the dyspnea, abdominal distension, and reduced urine output. Urine output per 200 ml per 24 hours. This time vital showed 110 per minute pulse. Blood pressure was 70 by 50, respiratory by 26 per minute. Physical examination revealed again pallor, pedal edema, abdominal fluid seal, and bilateral basal cracks over the lungs. Blood investigation showed acute renal injury, hyponatremia, as we can see in this table. So creatinine and blood urea, nitrogen was elevated, and potassium was also elevated along with the lower sodium. AVG showed hypoxemia, saturation was 88%, and a mild metabolic acidosis pH was 7.35. And chest X-ray again showed the minimal pleural effusion. Serum profile and blood culture sensitivity were done, but was actually non-significant. So this time, with the suspicion of acute renal injury, diuretic was stopped. Oxygen inhalation were given at 4 liters per minute. IV albumin, again, we started IV albumin injection noradrenaline because patient had hypotension, and a little IV fluids and broad spectrum antibiotics. These vitals had started to show improvement. Saturation comes to 96, and blood pressure was also elevated to 78 millimeter of mercury. However, after 2 days, his urine output further decreased to 100 ml per 24 hours, and his potassium increased from 5.6 to 6.8 milliequivalent per liter. And repeat AVG showed pH of 7.2, suggestive of metabolic acidosis. So, hepatorenal syndrome type 1, likely diuretic induced, was diagnosed, and injection terlipressin was started at the rate of 2 mg 6 hour infusion. Nephrologist opinion was taken and advised for dialysis. However, the problem of because of low systolic blood pressure, hemodialysis, they were actually not able to start hemodialysis. Therefore, we decided to increase the dose of midodrine, and it was increased to 12.5 milligram TID in view of the low blood pressure. And it worked, and blood pressure actually improved from 78 millimeter mercury systolic to 92 millimeter of mercury, and nephrologists were able to do the dialysis, hemodialysis, and patient required 3 sessions of hemodialysis for recovery. After 5 days of therapy along with the dialysis, his renal functions had started improving, and ultimately he was discharged after 10 days of admission. So during follow-up, once renal function were improved. Diuretics were reintroduced with the strict dose titration. Currently, he is tolerating only 80 mg of furosemide and 200 mg of spironolactone, and he is requiring almost 4 to 5 sessions of large volume paracentesis, and he required 4 sessions of LBP in last 2 months. The frequency of ascites drainage decreased from 6 procedure to 4 procedure because maybe because of midodrine or something, or patient recovers. So I don't know exactly, but he's maintaining his systolic blood pressure between 90 to 100 on the midodrine 7.5 TID. So during dialysis, we step up the midodrine dose 10.5 TID, but once patient settled and patient able to maintain his blood pressure more than 90, so again we reduce the midodrine dose. Because there is no clear-cut guideline, so we just did the things according to the systolic blood pressure. He is also taking currently Nortox 400 for the primary prophylaxis of SBP because ascites fluid albumin was low and salt restriction and other standard treatment. So to summarizing my case, a 45-year-old chronic ethanol abuser, a known case of polycystic liver disease, presented with ethanol-related CLD, portal hypertension, ascites, and grade 1 barracks. The patient was treated with the alcohol de-addiction, dietary modification, diuretics with a step-up approach, and oral irons and B12 supplements. And dose of diuretics were gradually increased, and patient initially tolerated 120 mg of furosemide and 300 of spironolactone. Here I want to say, in my experience, little experience, usually, I don't know, Indian patient usually do not tolerating this 160 mg of furosemide or 400 on the spironolactone. Most of the time we stuck up with this 120 mg of furosemide or 300 mg of spironolactone. 1 year later, he had developed this refractory ascites. It was because of diuretic intolerance and treated with recurrent LBP. And later on, midodrine was added because of the lower systolic blood pressure. And the addition of midodrine leads to the improvement in systolic pressure little and decreased requirement of LVP slightly. And 4 months later, patient suffered again from a diuretic-induced HRS type 1 hypotension. And this time, dose of dimidodrine was increased to 10.5 mg TID will help in elevating blood pressure and subsequently for hemodialysis. Presently, the patient is on diuretic and repeated LVP and 10 mg midodrine and 7.5 mg midodrine TID and other appropriate treatment. Thank you very much, sir.
Thank you, Ashish, for a nice presentation. And I think you were very fortunate in this particular patient. He went through HRS and refractory ascites, and yet he's doing reasonably well. Though we really don't know what will be the long-term status of this patient, and when are you able to give him renal transplant, liver transplant is the question. Now, you yourself raised a couple of issues, and there's a question from Dr. Chetna as to how many of us are able to reach a 400 milligram of spironolactone and 160 milligram of furosemide in our day-to-day practice. Dr. Konar, do you think that dose is usually not possible in our patients? Do they not tolerate this dose? Dr. Konar?
Actually, it's basically it's a response guided. I mean, we look after, but basically I thought that, most of our patients who tolerate 80 milligram of furosemide and 200 milligram of spironolactone. Some of us have treated always, started with straightway 400 milligram of spironolactone and then adding up furosemide as and when necessary. But I think when we are gradually mounting the dose, probably 280 is usually tolerated. But nowadays, because patient, as you said, I think in the beginning, the patients want rapid results. We do not wait for the diuretics to happen. We start with LBP. Somebody who is having, you don't wait till they get to the stage of refractory ascites.
Can you unshare your slides, Ashish? Can you unshare your slides? Can you stop sharing your slides so that you can have all the panelists here?
So, when we reach a point where 200 milligrams spironolactone, 80 milligram furosemide is being given, patient is not responding. I mean, responding to the extent as you have wished, and that, 4 days is not losing 800 milligram. two things I thought from Ashish's case, he hasn't done the, later on in the period, it looks like it was a AKI rather than a HRS. There was not, and I mean, not discriminated very well. There was no tests for urinary deposits. There was no urinary angle, or, you know, it looks like that he had a AKI rather than an HRS. And for HRS, he did not show us with the given, you know, Birendra Singh's results shown that if you continue to give midodrine, there is a good sodium excretion. So at the height of this patient's life history, this urine volume and sodium excretion was not mentioned. These are, I think, some of the points. And I thought there should be a debate about AKI and HRS type 1, especially in this case. And probably it is AKI. That's why the patient got better with dialysis and everything. But of course, you know, there was hemodynamic support from the midodrine. Whether we should have used talipressine alone. I mean, you are using two vasoconstrictors. Patient was given talipressine. Patient was on talipressine, and there is a, you know, and also albumin, and then also midodrine. So that I thought was a bit, either we give noradrenaline or talipressine in this acute ICU scenario, rather than in the outpatient.
Ashish, you don't want to take the question of AKI versus HRS in this patient?
Yes.
Which I wanted, if I can ask one more question. 12.5 milligram 3 times is a very high dose. How many times have you used this dose earlier? Because we have hardly used this high dose of 12.5 milligram 3 times.
7.5.
So these are the two questions for Ashish before we pass on to our panel discussion.
So, sir, question number 1, AKI versus HRS. Actually, we investigated for a urine examination was done for the routine examinations for protein estimation, for RBC estimation, and for culture and other things. And it was normal, absolutely normal. And as per the criteria of HRS, initially it was actually first 2 days adequately albumin was supplemented. So our patient was deteriorated after giving the albumin, and after 48 hours in 3rd day. So that's why we think it was HRS type 1. And obviously, because follow-up is just 2 months, so mortality is high, we all know. So we don't know the what will happen in coming months. So I am clear it was HRS 1. And question number 2 was regarding the dose of midodrine. Sir, I was used at that time because for dialysis, but immediately after that, I actually reduced one special dialysis, and AKI crisis was over. So I reduced the dose again to the 7.5. So I never used. I never used for long this high dose.
Is it, from my knowledge, is midodrine removed in dialysis? Is a dose needs to be increased because is midodrine removed during the dialysis?
Yes, because it has been renal excretion, sir. Because it has renal excretion.
Okay, now with that, I think a very good presentation by Ashish. Can we have now some question answers? I can see about 10 questions in the chat box in the question answer, and I can invite now Dr. Sethi, Dr. B.B. Pal, and Dr. Kamal Chetri to join us. And of course, Dr. Konar, Dr. Sujit Chaudhary, and Dr. Ashish Jha will remain here. So the first question is to Dr. Sethi. These are some pre-formed questions which I framed today. Dr. Sethi, is refractory ascites a common problem? We discussed about 5 to 10% incidence. And is in your practice, it is more of a diuretic resistance or diuretic intolerance? Which is more common in your practice?
Like we have discussed, it's very common. Almost 5 to 10% of all the cirrhotic ascites are diuretic resistant refractory ascites. So mostly we see diuretic intolerant, and we hardly able to reach the high dose of 400 milligrams spironolactone or 160 milligram of furosemide. At that time we have complication or some.
So you find most of the time it's an electrolyte imbalance or muscle cramp, or encephalopathy. What is the most important reason for calling it a diuretic intolerant in your practice?
Electrolyte imbalance and AKI. Both are more common than muscle trams.
All right, thank you, Dr. Sethi. And now my next question is to Dr. Pal. When you manage refractory ascites with large volume paracentesis, do you give albumin all the time? Is there any midostaurin in addition to albumin or in place of albumin to avoid post-paracentesis circulatory dysfunction? Do we have any studies which have shown that we can replace, albumin is very costly, and can we replace albumin with midostaurin or with some other solution? And what do you do to reduce requirement for large volume paracentesis? Dr. Pal.
Yes, sir. I think the refractory ascites already Dr. Sujit Chaudhary has nicely put in. That is, it's about 2 weeks. That is, if we are going for a salt restricted diet, absolutely, that is less than 2 gram salts. And along with that, if we find that sodium excretion is, sir, is round about 78 millimole by urinary sodium, then obviously, if we want to go for a 8 liters tap each, LVP, then I think it comes to about 2 weeks every, we require this LVP. And next point is, yes, definitely if it is, if we are tapping more than 5 liters, it's prudent to use albumin. If it is less than 5 liters, maybe we can, it depends upon our clinical judgment. And here I think is the role of these two coming. Any alternatives to albumin, like we have this actually the midodrine. So actually midodrine has been used for this refractory for this as a alternative to this post paracentesis circulatory dysfunction prevention, and it was found to be quite effective. I think Shujit also showed that data.
Do you agree that there is a controversy about this, whether some of the studies
Sir, okay, sir, then because we didn't speak anything about the, the limitations of actually midodrine, but if we see the largest randomized control trial, that is the MACT study, which was published by Sola et al. In Journal of Hepatology, January 2019, we'll find that a combination of midodrine as well as midodrine and biweekly albumin infusion, and midodrine was used in quite a high dose there. 60% of them actually received 30 milligram per day, and about 40% of them received about 15 milligram, and it didn't show any benefit either in the primary outcome of preventing liver transplantation, or delaying liver transplantation, or secondary cutoff points like decreased paracentesis, because this was a big randomized control trial. So but however it was,
my other concern, Dr. Bhaskar Pal, is there when you are giving midostaurin as to prevent post paracentesis circulatory dysfunction, this is not a rapidly acting drug. Albumin reduces its effects immediately. So we start albumin during the paracentesis and continue it for some more time. But midostaurin, will you start with that aim? Will you start it before you do a paracentesis? And how long will you continue midostaurin in that situation? I think this is a very controversial area.
Yeah, they have been used actually, sir. You see, for 2 or 3 days, this study which Sujitha showed. So they have used it for, I think, for a single, for 2 days only, while they before starting the tapping, and then after tapping, continued for another 24 hours. And another few, terlipressin has also been used as an alternative to, but again, terlipressin is very costly, maybe even more costlier than albumin.
What about dextran?
Dextran, sir, I have got no experience, and I have not used, because there have been a lot of these probably coagulopathies and other, hypotension and all those things. So I have got no experience of using this dextran or hexaethyl starch.
Yes, there's a question from Dr. Swambhu. Is this dose which is required for albumin in this situation? Do you use the same 8 grams per liter of fluid removed, or do you use lesser dose, or what dose do you use?
So we use a standard dose, 6 to 8 grams per liter if it is above 5 liters.
I don't know why Swambhu asked this question. What is in his mind? Because I think there is no reason why Indian scenario we should use less than the Western scenario. I think the standard dose is 8 grams per liter of fluid removed if you remove more than 5 liters. Now, my next question is for Dr. Kamal Chetri. When actually do you think as we should add midostaurin in the treatment of refractory ascites. And there is an added question which has been asked by one of the attendees today, is that should you start it only in patients who have hypotension, or can you start in patients who have normal blood pressure or high blood pressure also?
Thank you. Thank you, sir. Now, the first question is when should we start? Now, as per the recommendation of one of the societies, we start only in refractory ascites when we have repeated large volume paracentesis and patient comes again and again with the problem. Despite your albumin and paracentesis, the recurrence becomes too frequent for the patients to manage. This is number one situation when we usually use it as the dose was discussed, 5 milligram. At the best we are using, but we have never used beyond that. And regarding normotensive patients, when you think of starting without hypotension, there is evidence that even if we use in normotensive patient with mean arterial pressure within normal range also, it shown to be effective. Although in some of the studies, it was shown that only in patient with hypotension, it is basically intended to be used. But with the normal blood pressure also, in some of the studies, it is shown to be effective and potentiating the efficacy of diuretics.
Okay, Dr. Sethi, my question to you is that can we use midodrine, should we use midodrine only after we have defined it as a refractory ascites, or can we use it earlier to prevent ascites to become refractory? Or in other terms, can it convert a refractory ascites to a sensitive ascites, if I can use that term?
If you review the literature, even today, Dr. Chaudhary has reviewed literature. I have very limited experience, but it seems that with midodrine use, ascites gets mobilized better. That means the requirement of LBP, the requirement of tapping is less with use of midodrine. So in another way, definitely there is a requirement of is less.
My next question is to Dr. Pal. Dr. Pal, there is a lot of discussion which we already had as to what should be the initial dose. Should we build up the dose of midodrine? And if yes, how do we titrate the dose? What should be the highest level we should reach? And what is the duration of therapy? Is that unlimited? You can continue with midodrine for a very long time?
So first of
tell us about this.
Yeah, first, so what they have suggested is there is a wide variation of dose. Sir, if you see Professor Virender Singh's actually study, so there they used a dose of 7.5 milligram TID. But if you see up to date, where they have used a dose which Dr. Sujit Chaudhary mentioned, up to 17.5 TDS. That's the highest dose I have come across. And most of them have actually used 5 milligram and they have titrated the dose actually. They have started with 5 milligram and then they have added 2.5 milligram. So that's, I think, and I think Dr. Jha's case also showed very beautifully that starting with 2.5, he has built up the dose quite effectively. And as regards the duration, if we see the studies, sir, none of the studies have shown that it was used for more than 1 year. So we also don't know that how long it should be given. If you see the MACT trial, the number of that is the maximum duration was given was, sir, this is 365 days or 48 weeks. And Virender Singh study also showed 330 days. So more than 1 year, we don't have any evidence actually.
So that answers, Dr. Jayant Mukherjee has asked the same question. So that answers that question from Dr. J. Mukherjee. Now, Dr. Kamal Chhetri, we talked about titrating the dose. So once you start a dose, how frequently should you increase the dose? What will be the guidance for increasing the dose? Is it a fixed duration you should increase? Or will you titrate it with some side effects or with mean arterial blood pressure? How should we increase the dose?
Obviously, the side effects and the patient's clinical course would be very important. The main point which would be important to monitor is the mean arterial pressure in these patients, and also carefully look at the other side effects like cardiac and other side effects of the drugs. Like,
So what is the blood pressure, mean arterial blood pressure, which will...
usually the guidelines, the various studies they have followed is 85 plus minus 10 is the mean arterial pressure that is followed. And mostly the Professor Virendra Singh's study also, they have followed 85. They've got in the treatment group, in the midodrine group, they have found that 85 plus minus 10. So that should be actually a guidance to follow the titrate the dose, and maybe a weekly dose increase, as earlier speaker was already, Dr. Pal was telling that maybe start with 5, then increase to 2.5 and titrate the dose accordingly, see the response, and also carefully look at the side effects, because the patients are very sick, and if any kind of side effect, particularly the cardiac side effect, the patient might have hypertension and then bradycardia, and others. Pruritus is also reported, very common side effect, pruritus. So these kind of side effects should be observed, and then accordingly titrated the dose, see that the desired effect of diuretic, the ascites mobilization or reduction in creatinine, if it occurs, is fine. That's what we should be careful at.
Sir, I want to just add another point.
Yes.
I think Dr. Konar also mentioned is to see the urinary sodium excretion, because with midodrine, all the studies they have monitored actually the urinary sodium.
And
Sir, I have got one question to. Oh, yeah. Sir, I have got actually one question to all my seniors, because if we see conceptually, actually midodrine is being metabolized in the liver, and its active metabolite is being excreted by kidneys, and we know it decreases the cardiac output. So I mean, because as you have, sir, shown that it is sometimes very difficult, as Dr. Chetria said, that suddenly the patient even might deteriorate, might develop a renal failure. So I don't know actually. So conceptually speaking,
Actually,
can we give it to
ARF
child C patients and all those things?
Sujit is
ARF
answering that.
Yeah.
excuse me, ARF is a contraindication for midodrine.
Yes,
Okay.
yes.
So according to the literature, that ARF, if it is a standard, ARF is a contraindication. But renal dysfunction in the cirrhosis is a hemodynamic alterations. So you are giving albumin and then improving the by albumin you can correct the
That
also.
question is more
but
clear now.
there can midodrine can be given, but ARF is a contraindication.
So Sethi, Dr. Sethi, no drug is without contraindication and drug interaction. So tell us, what are the drugs which you should avoid while patient is on midodrine, and contraindication? We already heard one of them. Are there other
I
contraindications?
think there are other contradictions like any severe organic heart disease and urinary retention itself and contradiction, pheochromocytoma, uncontrolled poor hypertension, and thyrotoxic is a real absolute contraindication. Then there are groups of drugs which are basically kind of interaction, that is all sympathomimetics, and drugs cause bradycardia, MAO inhibitors, and for us I think linezolid is also important drug, and that can have drug-drug interaction. Then we have procarbazine, TCS. We are commonly using TCS. Should be avoided when using this drug.
I was surprised at that study. I have not had a chance to look at it. Is rifaximin being combined with midodrine? I think it is one drug which is being combined with everything. I don't know what is the logic of adding rifaximin to midodrine, Dr. Sujit.
Yeah.
Can I ask?
mentioned that.
Yes, Dr. Kona.
It is.
Yeah,
I thought it was a proof of concept study. I actually read that article about a year ago. They said it's a proof of concept study for gut dysbiosis, bacterial translocation, and worsening. That is now the new theory.
Rifaximin people are adding for everything nowadays, and
because in everywhere there is this microbiome and all,
Actually,
dysbiosis and all.
rifaximin is targeting the etiopathogenesis of the dysfunction, that mechanism of decompensation in cirrhosis.
All right, Sethi, while you are at drug interaction, there is a question. I think this is a very open debate when to stop beta blockers in patient with decompensated liver disease. There is a question from the audience also. The status. So what's the jury? Jury is out.
I think Dr. Chaudhary discussed also regarding beta blocker in child C cirrhosis and decompensated cirrhosis should avoid beta blocker. At the same time, beta blocker also causes bradycardia, and you should avoid the beta blocker with midodrine. in this type of patients.
So there is one more question which has come up from Dr. Rishu, who is asking whether there is a risk of internal bleeding while the patient is on midodrine because of higher blood pressure, which it can create. Can there be a bleeding inside? Is there any documentation like that?
No, I don't think this is important.
And there is no
Sir,
document.
actually, can I add? Sir, can I
Yes.
just add? Because
Yes,
I had 2 patients on midodrine, and one of the patients, sir, actually developed a portal vein thrombosis, and the other one, both were elderly ladies, and the other one developed a pancreatitis after starting midodrine.
Yeah, pancreatitis is
is
known
it-
complication.
Yeah,
Pancreatitis is
yeah.
known complication.
So I think these are the of my experience regarding the.
I don't think, Bhaskar, we can say that it causes increased portal vein thrombosis because of one case which you.
No. I know, sir.
No,
That
no,
is
no.
my very limited experience.
Maybe
Okay,
unrelated. Yes.
so a question to Dr. Pal again is that if you have 100 patients of refractory ascites, how many of them land up with TIPS, transplant, large volume paracentesis, and midodrine in your experience?
Sir,
Which are the
most of
patient? Let me complete the question. There is
Yes,
a
sir.
question from one of the young gastroenterologists. Which patient should be subjected to TIPS?
Sir, actually, I think
Of comparison of TIPS with alpha pump. What is the comparison? I don't think
Sir,
any of us have experience of alpha pump, but can TIPS
sir,
be compared?
but I think Dr. Chaudhary has lain rest to that controversy, because we are comparing actually oranges to apples, because as Dr. Chaudhary very clearly showed that alpha pump does lead to AKI, and the last study which appeared in Journal of Hepatology 2017, and they showed that definitely AKI was linked to it, and they have suggested that probably patients who are on alpha pump, they should be given either weekly or bi-weekly albumin in order to correct this AKI. So I think, but TIPS itself, by decreasing the pathophysiologic mechanisms, can rather ameliorate the HRS or these things. So I think comparing TIPS to alpha pump is will be doing a great disservice to TIPS. But I think Sujita has beautifully told us about the contraindications, and Ashish has shown by that beautiful case presentation that most of the time there are certain, we cannot go apart from the that is the financial factor. Things are the contraindications, like the heart, that is the heart disease, because we know that ejection fraction must be above 60% in order to have, because pulmonary edema is during the first 24 hours, even we had patients going into ventilator and all those, and also encephalopathy, any history of encephalopathy and all those things. And though with the Gore-Tex stent, this portal vein, this thrombosis of shunt has decreased to a great extent. But I think the indications are there, but the contraindications and putting in the check boxes for that whether this patient is above 65, because most of them sometimes we feel that they do not actually fill the criteria, and if they fill the criteria, they don't have the funds.
Dr. Bhaskar, thank you for that comment. Now, before I ask the last question to Dr. Kamal Chhetri, there is one or two interesting questions which have come. One question is from Dr. Johan. He says that he has experience of 3 patients who underwent TIPS, and in spite of TIPS being patent, the patient's refractory ascites did not improve. So is there any explanation for that? Any one of you, if you can think of some explanation for a functioning TIPS and yet ascites not responding?
I think the salt intake should be checked if the patient is on proper salt restricted diet and then he's following that. And on the top of TIPS also, sometimes we have to add diuretics to mobilize the ascites properly. So that should be looked at, I think. No,
and I think we should look for other causes of ascites in this setting.
Sir, yes, and another point I think, sir, is that I think because we heard that lecture by Madam Usha Goenka, where I think the technical issues are also very important, sir. That is actually where do you keep the the distal end of the shunt, whether it is at the at the IVC junction, or it is it might be functioning, but it can be near the that is the hepatic venous and the IVC. So technical issues are also important. It might be functioning, it might be patent, but if it is not at the just at the junction a bit about near the IVC, it won't actually lead us to the, you know, mobilization of the ascites by decreasing the
With my
pathophysiology.
There's somebody called Dr. Dolly Gupta. I'm sorry, I don't know you personally, but she
I think
that you increase the lumen size of tips and possibly the size matters.
I think Dr. Vikas must be. He must be Dr. Vikas.
No, Dr. Dolly Gupta.
Yeah.
Until it's somebody else's number.
Because
Anyway,
she's now with.
Okay, the last question is about what is the expectation from the pharma industry? Are you happy with midodrine or you want new drugs to develop? I would also like Kamal to comment about clonidine. We know that clonidine in some selected patients with very high plasma renin activity possibly can be a good drug in this situation. Dr. Kamal Chetri.
Yes, sir. There was
What do you want myelin people to develop next?
I want to develop. I want them to develop livers for everyone. That is not possible. But now, as far the drug is concerned, the efficacy of drug has been discussed. Its indications, its side effects, its where probably we cannot use also. But now the main issue is the question is the cost. What is the cost of the medicine that is for the patients to pay? So other options are like liver transplant is most of our patients cannot afford. There is no probability of getting liver transplant, which is the best treatment. And the second best treatment seems to be TIPS, which is again having limitations of expertise as well as the cost, and problems related to TIPS itself are there. Now we'll end up doing large volume paracentesis for this kind of patients with refractory ascites.
So I'll tell you one good news to this limited audience. Talking about liver transplantation, you talked about not affordability.
Cost is a concern. Market cost is 2,500 rupees. So one tablet is around of 2.5 milligram tablet costs around more than 100 rupees per tablet. So 1 day treatment of 2.5 milligram cost you around 375 rupees of as per cost.
I agree. So I was just talking about liver transplantation.
Yes, sir.
I was just telling you about liver transplantation that we saved some money from our APDW and we have decided that for the next 10 transplant, we will do it half the cost. So I think maybe some of the patients can be utilized, whatever money we saved in APDW. So
thank you for that.
Thank you, sir.
So for the next 10 transplant, we'll be able to do it for that rate. Now, the last comment from Dr. Konar. Sethi, you wanted to make some comment?
Yeah, actually, I was just asking one question to everybody. How, like you are also asking, how early you can start midodrine? Like anybody ascites, just ascites, no renal failure. And how early you can start midodrine?
I think it will be wrong to start midodrine. It will be wrong to start midodrine in the initial management of ascites. We should reserve it
unless
high dose of diuretics. We may not be able to go up to 400 and 160 combination, but at least some significant high dose of 200 milligram plus 80 milligram. And after that, if the patient doesn't respond, we'll consider midodrine, and we must titrate it with mean arterial blood pressure and with urinary sodium, which was mentioned by Dr. Konar. So Dr. Konar, your final concluding comment.
Thank you, Dr. Goenka. I think I'd start by saying that if you look at Virendra Singh's article, he actually managed to see only 12 out of 40. 12 were actually your refractory ascites. Most of them were actually recurrent ascites that we face day to day. So I think that's the type of population that we are trying to, give this drug should be selected properly. That is the first thing. Second thing would be that if we give midodrine, we should also we should look at not only the blood pressure, the cardiac side, but also we should look at the urinary volume and urinary sodium, so we can really see that the patients are doing well. Because in Virendra Singh's study, you see that with 3 months there was a very good effect with statistical significance. But if you look at 6 months data, the urinary sodium, urine volume, blood, everything actually were not statistically different from the standard medical care. So if there is a question of tolerance that we have to decide, and why it is not being recommended by everybody. I mean, that is a question I think remains to be answered. Second thing I would like to point out that beta blocker, I think there are proponents and there are people against it. Obviously, this is a situation where Cardiovas should not be used, but beta blocker in small dose has many good effects. So one has to be very careful if we have to use beta blocker, because if the blood pressure is low, I think we have to see the systolic blood pressure is low and the kidney is not doing properly, then we have to stop beta blocker. Otherwise, small dose of beta blocker can be used. Third thing, tips. Dr. Goenka has the experience, and also we have a lot of experience for a long time. And most of the people with tips have done well. Only one patient that we recently had that the problem has, somebody asked a question where the large, amount of ascites was present. Patient did not respond to tips. In that patient, we found that actually the hepatic venous pressure gradient did not come below 12. The targets of tips should be that the hepatic venous pressure gradient should come below 10. If not possible, sometimes the radiologists use smaller diameter tips catheter, tip stent, because so that you don't have encephalopathy. But if we do a large bore stent, then obviously there will be a reduction in the HBPG, but there will be more chance of encephalopathy. So usually 8 millimeter stent is used. But what happens is sometimes if the HBPG does not go below 10, that is the clinically significant portal hypertension, then there may be a case for ascites persisting. And third thing is, following tips, it takes about 6 to 8 weeks to start diuresing. That means sodium excretion following tips takes a longer time. So I wouldn't expect that I have put a tips today, it will be effective after 1 week. And lastly, I should think that those of our patients, some of our patients will be actually affording transplant, and transplant is being available everywhere a little bit, easily. So I think we should counsel them for transplant. If we tell them when this situation is very bad in HRS or whatever, then the time is lost. If we find that somebody is gone from the grade 3 ascites to refractory ascites, I think it's the time to counsel them for transplant. I think with these few words, I should hand it over to you.
For those concluding remarks. With that, it's my pleasure to thank all of you who are present, both as moderators, as speakers, panelists, as well as to the organization for supporting us. So Dr. Jha, Dr. Kamal Chetri, Dr. Sethi, Dr. Suji Chaudhary, Dr. Kona, Dr. Bhaskar Pal, and all the panelists who were present and who interacted with us during this session. Thank you very much and good evening, everyone.
Good night. Good night, everybody. Good night. Thank you. Thank you. Good night.
Thank you, sir. Good night to all.